I'm here to represent the South Carolina Surgical Quality Collaborative, and I'm only supposed to wear that hat. But I have other hats, and I think they may be relevant for this particular audience, which is I also work in the VA. Yes, the world's #1 medical piñata. Everybody hates the VA and thinks the VA provides poor care. And I'm going to go through the South Carolina Quality Collaborative stuff pretty quickly, since we're modeled a lot off of Michigan, and some of the stuff that Skip and Eric have talked about are redundant in my talk. I do want to bring up some of the things that are going on in the VA that I think would be relevant to the discussion for DOD. First of all, congrats for finally deciding to go to a real electronic health record, because every time I log into Vista, if y'all know what that is, which is the VA side, which is now I think 53 years old, I just want to shoot myself in the head. So anyway, I'll talk about the collaborative first, but there are some parallels between my job at the VA. I'm the Chief Surgical Consultant for VISN 7, so I'm responsible for the quality of surgical care in Georgia, South Carolina, and Alabama across our 7 programs, and I was, until recently, a member of the General Surgery Advisory Board for the VA, National Surgery Office. Okay, I don't have any disclosures, but I'm willing to discuss it. If anyone has any good ideas, I'm happy to get money from somewhere else. So the Quality Collaborative, and you know, you're federal employees, so am I. That's most of my salary, so we're always looking for a better deal. So South Carolina Surgical Quality Collaborative is a joint effort to improve the quality and value of surgical care in South Carolina. It is modeled very much off of Skip's guidance, and Blue Cross Blue Shield Foundation has funded us for 3 years. It's a web-based platform, has central administration. We only have 8 hospitals. Skip's group started with 10 or 12, and they've grown to 73. So that gives you an idea of the success that a collaborative can have, and we're hoping to have our 10 and 12-year annual meetings down the road. Each site has a data abstractor and a surgeon lead. We have monthly calls and quarterly face-to-face meetings, just like Michigan. We've added a patient and a trainee engagement part to this. I have 3 trainees from my program in this room right now because I told them I was going to be here, and so they feel bad, and so they figure they better drop by rather than go, jogging around town and seeing Houston. So they're here. In 5 days, they will be able to go onto our website and see their outcomes. Okay, that's unique to our collaborative as far as we know. We're trying to improve quality. We're trying to improve value. We're trying to learn from each other. We want to establish a culture of cooperation and continuous process improvement. We want to share best practices, and we want to make quality improvement efforts more efficient and less costly. We don't want to reinvent the wheel. If you do it well at your place, I'm happy to steal from you and then take it to my place. What we're not peer review. We are not using this data in any way to penalize anybody. If you're not doing well, that doesn't mean I'm going to go or tell an administrator at your site that you're not doing well and therefore you need to be fired. We're going to go and try and help you do better. And I would hope that someone would do that for me. If my surgical site infection rate is too high for a colon operation, I want someone to help me get better at what I do. It's the right thing for my patients. It's not data for marketing purposes. Nothing goes up on the billboard that says we're #1, right? It's not data to cut payments or prevent referrals. Even though it's funded through Blue Cross Blue Shield, they do not get any identified data. So they can't look at like Skip's red bars and say, we're not going to send bariatric patients or colon patients to the red bar hospitals. That data is not available to them. It's not a way to tell hospitals and physicians how to practice, but it is a way to give physicians and hospitals tools they can utilize to improve patient care. We might suggest ways that you can practice using antibiotics, as Skip mentioned, ERAS protocols, those sort of things, but we're not going to tell you what to do. Just our vision to be the best, basically by 2019. I'll skip through the mission because that's just the verbiage. This is what it really looks like. We have a clinical leadership group, a patient engagement group, the surgeon lead, which is what I am, and a program manager, and the hospitals and a data coordinating center. And all of those function together to create the collaborative and to set up the quarterly meetings. We have a patient questionnaire that we've developed, and each hospital is doing 100 questionnaires to try and figure out the patient level factors that may be contributing to outcomes. Anybody ever sent a patient home and told them to take off the dressing in 48 hours and they come back to your clinic 2 weeks later and there's the dressing? Yeah, so those kind of things. Or you drain some pus and you think they know how to do what the dry dressing changes or to keep it open, and they come back with the same dressing in, or it's sealed up a day later. Those kind of things are the things that we're looking at to try and improve outcomes along those lines. This is where our hospitals are, and just to give you an idea of the relevance of how different hospitals function, and Skip showed, good area of Michigan and how it's not just academic institutions. Practices are very different across these hospitals. We have large academic institutions. Mine's the one that does 28,000 cases or so a year. We've got some that do less than 2,600 cases a year and only have 4 ORs. Those are very different hospitals with different resources, and we can help each other get better. I can go to librarians who can do an evidence-based review for me and tell me what the best antibiotics are for a colon case. My smaller hospitals can't do that. I can share that information with those smaller hospitals, and that's what we do. So the hospital's role, each hospital has a surgeon lead and a data abstractor. The surgeon has to develop a culture of continuous process improvement. The hospitals make themselves better. And when we first started this, and we're early in the process, the first thing was we had to build trust with the surgeons. Surgeons thought we were coming in to tell them how to practice. We were coming in to say, you're doing a bad job, your CAUTI rate's too high, you're transfusing too much, you're bad, 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 bad. They didn't trust us to believe that we were just trying to actually help out and learn from each other. And so it took a lot of effort on my part and individuals' parts to build that kind of relationship and to show this wasn't another just Medicaid or Medicare sort of information system that tells me I'm doing something wrong. This is what it looks like. Just log on. We're looking at general surgery, so those are your basic operations that we use the CPT codes to code. We do, like most collaboratives, about 25 cases over an 8-day cycle. We get this is a medical university, which is when I'm at the academic affiliate and not at the VA. This is their results, and so if I'm logging on as an MUSC physician, I can see where my morbidity and mortality is relative to the rest of the collaborative. This is what it looks like if I want to look at my own data. So if you look at the very bottom of this page, you can see where the little checkbox that says surgeon specific. So what I can do, and of course I chose one where I'm the little green bar there, that's Mark Lockett, and if you notice I'm below the line, so that means I'm good, right? So I chose at least on morbidity that this is all the surgeons at my facility, and the sort of median bar there, comparison group, is the average for the collaborative. So I can look at morbidity, I could look at my length in the OR, I could break it out by CPT code. If I were a bariatric surgeon, I could look and see compared to all the other bariatric surgeons in the collaborative what my operative times are, what my return to the ED was. And if I look at it and I say, wait a minute, I've got a transfusion on a mastectomy patient or something, I don't remember that, I can drill down to the individual patient's data and figure out why that ended up counting against me, if you will. This just gives you an idea of some of the things that we found. Overall morbidity is a little over 10%. Mortality rate's about 2%. I won't go through all of these, but you can just see, and I can drill down to any one of those for my individual practice. And again, for the residents in the room, they'll be able to do this for their practices in about another week. So why should I care? Well, providing the highest quality care at the lowest cost should be every surgeon's goal. High quality care improves the health of the patients we serve. Surgeons need actionable data to improve our practices. A lot of the acronyms that Eric put up there, I would say, are not necessarily actionable, or at least a lot of the surgeons don't believe what some of those acronyms show. Surgeons must trust the data and the process, and that's building that belief in the system. So what about all the metrics? What about all these other acronyms that we have to deal with? How does the quality collaborative help with that? My hospital administrators honestly don't care very much, and I'll give you some examples as it relates to my federal job about these abstracted datas, and I'll get to that in just a second. They want to know about the coding data information, which is what feeds into things like hospital compare and all these star ratings. And I got another slide in just a minute. I'll expand on that a little bit. But if you do all the right things for your patients and you get better at what you do, all those other things will follow in line. Those other numbers will look better. You have to stay focused on the patient, not on the number. And it's very hard to explain to some administrators, not Eric, because he's a surgeon, but it's very hard to explain to some administrators, and I'll give you an example of that in just a minute. Alternative payment systems we've already talked about are going to reward higher value care. We, surgeons in the room, need to own and understand our quality rating and management systems. If we don't, someone who doesn't know our business will, and that's already started, and we've given examples of that here. Getting better at what we do is just simply the right thing to do. Quality alphabet soups, regional quality collaboratives, NISQIP, trauma, Society of Thoracic Surgery. So a moment about the VA. So the VA, Dr. Shakuri at the West Roxbury VA is functionally the one who started, among others, started the VASQIP system, right? And that's where a lot of things spun off of this. And at the time, the mortality rate, and again, I'm not supposed to be wearing my VA hat now, but the mortality rate in the VA system was over, I think it was almost 4%. Since VASQIP started, that's gone down to now 0.8% across the VA system is what the mortality rate is. And it's been pretty steady there for a while. When I started at the VA 5.5 years ago, the report was the VASQIP report. It's now called the National Surgery Office report. The VASQIP report was about 4 pages long, and all it did was tell me whether I was an outlier from observed to expected with regard to morbidity or mortality. The report I got about 2 weeks ago is 53 pages long and has a 53-page interpretation document. And it is the best data that the VA puts out that I've seen. I can break down by subsection where I have morbidity or mortality problems. I even know the cost per RVU for my surgical segments, for my orthopedists, my ENTs, and that's all pulled out of data systems within the VA. So because we have one electronic health record, it helps. We have VSSC, we have other things that help pull all this data in that wasn't available in most of these systems, but as you get into a single unified health record, it allows you to be able to combine multiple data sets to be able to get very actionable, very reliable, and useful data. It's not perfect, but it's gotten massively better, and I can talk more about that offline if anybody wants to talk to me about the VA side of things. The VA in general has gone towards something called SAIL, and if you haven't heard about SAIL, I suspect you will hear something or it will have its own DoD acronym. SAIL is a coding-based data set, and I work at a 5-star VA, which means I'm in the top 10% of VAs across the country. That's based off of SAIL. So I got an email from someone I work with that said, such and such on SAIL doesn't look good. I emailed back and I said, well, on my National Surgery Office report, this had to do with readmissions, my hospital length of stay is a half-day shorter than national average, even though I have a more complex facility than the vast majority of VAs, and my readmission rate is 15% lower than the national average. I was able to respond to coding-based concerns based off of real nurse abstracted data that I know is reliable. We had a higher than expected, or higher than we were supposed to have, pneumonia rate at our facility. You know what we found out? Our residents were putting x-ray reports into their notes. And guess what coders do if the x-ray report says some consolidation in left lower lobe cannot rule out pneumonia? That gets coded as a pneumonia. And in your discharge summary, if you don't say pneumonia was ruled out, that code will stay in the system, and now you have a hack. You have a hospital-acquired condition, which was pneumonia, because you had a radiology report in a progress note that suggested there might be a pneumonia. That would never show up in the kind of quality collaborative stuff that we have here. Hospital compare, all these others. So real quickly, coding versus abstracting. I've already given you some examples there. Coding, the advantage of it are, it's 100% capture. When you're abstracting cases, you can't do all the cases. We get 100% capture when it's coding data. But it is coder and IT dependent more so than a clinician looking at a chart. It costs less because you don't have to have an abstractor. The budget for these, our grant's about $4 million. Skip's is way up there in the millions because he's got abstractors at all of those facilities and surgeon leads. The issue, though, is when you start manipulating the coding data, what your facility does is they hire coding specialists. Clinical documentation specialists are not cheap either. And so even though coding should be a cheaper way to get information, it tends to end up costing about as much as one of these collaboratives does. It's documentation dependent. It's coding rules not based off of quality, defined quality metrics. What is acute blood loss anemia for a coder? It's if you say acute blood loss anemia. So if we did a prostatectomy, robotic prostatectomy with retroperitoneal lymph node dissection and the hemoglobin went from 13 to 11, would you consider that postoperative hemorrhage? I wouldn't, but that shows up as a PSI in the coding data bank if, and I don't want to blame residents, it could be the attending said blood loss anemia after the surgery. No transfusion. In our quality monitoring system, we would have a defined number of units that would need to be transfused over a period of time to be able to call that hemorrhage. So we'd be talking about the same stuff. Accuracy concerns, and we find that most of the coding data banks aren't all that believable and actionable by the individual surgeons who are looking at that data. Clinical abstracting, auditing of abstraction to make sure it's accurate and the definitions stay the same. You have the ability to ask questions. Is something a surgical site infection? If you had a little bit of an erythema and you started antibiotics, is that an infection or not? Coding and abstracting can come up with very different answers in that situation. It is time intensive and there's sampling limitations. You can't do all the cases and it costs money to hire these people. But it is, I believe, believable and actionable. And it doesn't do you any good to have these collaboratives if you don't have buy-in from the people who are going to make things better. I'm not going to go into all the variables between regional and national collaboratives. There's variability in patient populations. I think that's especially true in the DoD, right? I just saw a trauma presentation where 83% of the patients were male, right? When I work in the VA, for me, it's about 75% of the patients are male in the VA. That's not the normal population out in civilian hospitals, right? So our bariatric surgery at my place is much more difficult than it is across the street. Why? Because male bariatric patients are harder to do and the vast majority of our patients are male, and a lot of them have had prior abdominal surgery. So you need collaboratives that are specific to your patient population. At least that's my feeling. But the main thing is you need buy-in for the people who are going to make things better. They've got to believe in the collaborative. They've got to believe in each other and the data that they're getting so that you can learn from one another and improve what you do. It's the people who make the difference, and if they don't believe the data, it's not going to be very useful. It makes people discuss things when you have a collaborative. We have to get together and talk, and that's how we learn. And it keeps the quality improvement fire burning, and it shortens the process improvement cycle. Skip's told us how to do stuff better. One of my facilities in South Carolina took his colon bundle. That's their project. They didn't have to recreate the bundle. They're going to try and improve their processes by using the Michigan bundle. That's going to speed things up by years. And it helps build key relationships so that we know each other and we can learn from each other. We need to focus not on looking good, which you can sometimes do in these systems, but on being good. Make sure that you manage the patient and not the metric. And hopefully these collaboratives that are data abstracted, where you sit in a room and you talk about the issues, are the types of collaboratives that will really truly impact patient outcomes and care and affect all the value stuff on the back end, but keep the focus on the patient on the front end. Thank you.